Hi everybody, it's Scott Forhan. For years I've been asked by my clients to answer the questions about what types of exercise methodologies would best be for them. Uh, this is a difficult question, and it's something that I've never given a generic answer to because everybody's different. So what I've decided to do is a Q&A series. So before we get started on our Q&A series, I thought it was really important that we discuss perspective first. So there's a few slides that I want to introduce you to. One of them is a surgery. This comes back from years ago when I was first exposed to the resistance training specialist program, and there was a video that was used to show a surgeon inside a shoulder joint and the nature of degeneration that was occurring within that shoulder joint. So that's going to be something that will help set the tone for what we're about to discuss. The thing that's really important for me as we go forward with this Q&A series is that it is not established that I am the end all and be all of knowledge of biomechanics, neurophysiology, and a lot of the other subject matter that we're going to enter into. But I have been a student of it for 24 years. And over that time, there's been a great deal of influence that different practitioners, different lecturers, different educators, different programs that I've been a part of, I've been able to derive a more global idea of just what is important when we consider developing an exercise program or a process. So I haven't gone anywhere. We've just switched to audio for a moment because I want to take a look at some slides from PowerPoint. We're going to do this back and forth because for me, I know it's easier when I read stuff. It seems to dissolve into me better. So I've written down simple things, I guess, also to help guide me along so I stay on the right train of thought. So often I am asked, where did I gain my perspective on exercise? And it's at this particular point, I guess while we're doing an introduction, important for me to kind of establish where I gained the insight on exercise that has made the biggest difference for my clients and my family, myself, all the people in my environment that I have the good fortune to touch with making recommendations or guiding them with regards to exercise. I was like anyone else initially, starting off in the gym culture. I was in my mid to late teens when I started doing resistance exercise with a good buddy of mine, and although he seemed to be someone who used a really slow kind of methodical approach to doing reps, and seemed that, in my memory we used a lot of good control over loads. In retrospect, the way that we chose exercise is the way that we chose load, the amount of rest that we chose was really more along the lines of what was going on in our social, cultural, fitness, exercise experience. And so there was really no attention to any kind of physiological details. I was immersed in the gym culture like anyone else. I looked at people training with weights. I saw guys who looked really big, who seemed to have a real ownership over the different movements that they were working within the gym with different types of loads, and and like any person walking into that world, having no idea how to train, I simply followed suit like most people do, looking for someone who represents a body type that is attractive to me, and then trying to basically in an undercover way follow along and learn how they train. After that, because of a really good friend of mine who was a personal trainer at the club I was working at, I got introduced to the National Academy of Sports Medicine, and there I was first exposed to Tom Purvis, who was the head of applied biomechanics, basically teaching the methodologies of analysis for different types of exercises, and creating a methodology with regards to how to develop an exercise based on joint structure, function, physics, the rules around force, speed, momentum, deceleration, so many attributes of what happens when a person gets involved with doing a resistance exercise in the gym, no matter what genre of exercise it is, whether it's bodybuilding, powerlifting, sports-specific training, rehabilitation. It was all relative to having an idea of how force is affecting the anatomy, and so I was very interested to learn that. And so from there, gaining a perspective of all the different variables that we were responsible for to become a certified personal trainer with the National Academy of Sports Medicine. Coming back into the gym, I realized that I didn't see any of that stuff going on in the gym at all. I had later been involved in a physio clinic. We had typical physiotherapy methodologies for rehabilitation that we would use, and when I was studying the work of at NASM and then going on to RTS, to take more in-depth courses with the RTS course with Tom, I realized more and more that as I was traveling to the U.S. and coming back to clinic, that there were significant differences in the perspective about what progression should look like when dealing with a rehabilitative setting. From there, for years and years studying the work of Kapanji because of the RTS program, and studying joint structure and function, and then moving into more specified texts on spinal function, getting more involved with studying myofascial tissue, myofascial trains, getting a perspective of the relationship between the neuromuscular system, the fascial system, and biomechanics and lever function. I was able to get a better idea of what was most appropriate as far as a progressive process of developing exercise, rather than somebody just coming into the gym and getting a program and having them work on that, and having no assessment as to create a basis for what that program should be started from. So then I was exposed into MAT, muscle activation techniques, which was a great fit because we were all studying biomechanics as an RTS group of instructors. I had become an instructor for RTS, and So going in and learning manual muscle testing was an enormous good fortune for me. Manual muscle testing came from the work of Kendall and Kendall, and I was exposed to it through MAT, which allowed me to go back and search more into the origins of where manual muscle testing came from, and how it was utilized as a tool by great doctors like the late Dr. Alan Beardall, the late Dr. George Goodhart, who were pioneers in the merging of taking biomechanical sciences, the studies of works of I.A. Kapanji, and looking at the angular function and articular function of arthrokinetics, and meeting them up with the demands for finding out how to use manual muscle testing to discern what type of therapeutic measures or what type of exercise measures would be the appropriate process for a client at any given time. Because of those two gentlemen, I then later got exposed to the work of Walter Schmidt, to David Walder, to Dr. John Brimhall, Dr. David Leaf, Dr. Evan Mladenoff, and lately Scott Cuthbert, John T. with Touch for Health. For years and years and years practicing, doing manual muscle testing into the hundreds of thousands, if not millions of manual muscle tests with patients, I was able to see where the commonalities lie between different types of descriptive diagnoses that occur in physiotherapy, athletic therapy, chiropractic, how those diagnoses measure into a biomechanical display within applied kinesiology. So because of applied kinesiology, I was able to say, okay, here's a person and they want to go into the exercise world, and when they want to go into this exercise world, how ready for the exercise world are they? Do we actually know where their positional weaknesses are? Do we actually know a lot about what they would talk to their doctor about and maybe not an exercise professional about? Do they have any visceral organ problems? Are they on medications for gastrointestinal disorders, kidney disorders, liver disorders? Do these people, so in the typical PARQ evaluation that are a standard in the fitness industry for people to fill out, a lot of these other issues were not going to be attended to. So as a result, the muscle weaknesses that one has around their ankle complex, their knee complex, their hip complex, their spine, their shoulder, these dysfunctions of muscle strength around these joints aren't just biomechanically related. I got to see, because of clinical and applied kinesiology and other methods of kinesiology, that the muscular weakness isn't always a biomechanical display. It's often an underlying visceral organ problem. So then, because of these guys, I started to be able to take a look at the acupuncture system's relationship with individual muscle groups throughout the body and how that affected biomechanics and kinetics, and set somebody up for their ability to go in and do resistance exercise in any type of performance, gym, CrossFit, whatever environment. The way that the person is going into the environment, now I'm able to understand why they run into difficulties with accomplishing their goals and running into a lot of developmental or cumulative chronic muscular and musculoskeletal disorders. Because of the study of applied kinesiology, with looking at the triad of health, I was also then exposed to the work of David Hawkins, who talked about consciousness, who talked about brain function related to consciousness. Then the work of Dr. Bruce Lipton, who talked about epigenetics and epigenetic sciences, the fact that they realized back in the 70s and then finally publicized in the early 2000s that Johann Krieg's idea of genetics was actually wrong, and that epigenetics would be the new science of the day, recognizing that it's not the nucleus that runs is the brain of the cell, it's actually the membrane that is the brain of our cells, and what those implications are on our physiology, on our immune system, on our visceral organs, on our neurotransmitters, and how those neurotransmitters can have a direct correlation to the way that we are capable of exercising on any given day. And because of those insights and the insights of Dr. Chris Astle-Smith from London, who runs the program Epigenetics, Functional Biochemistry, I'm able to recognize that there are specific pathways in chemistry, and that all of the rules that we need for evaluating the process for testing to see what is the right way to engage our patient, that all of those answers lie within the biology, the biochemistry, the physiology, the neurophysiology, and they're displayed in the muscular system. They're displayed in the biomechanics. So learning how perception relates to our physiology and our ability to achieve our exercise goals has been a 24-year growth for me, taking a look from the beginning at studying biomechanics into studying all of these other facets of the human experience on the triad of health, with the chemical, the emotional, and the structural or biomechanical sides to the triad. It's impossible now for me to just look at exercise and be vague and be generic about what genres of exercise are good and which ones are not. Instead of me answering the question, which different forms of exercise I think are beneficial, what would be my goal for these Q&A sessions is to better teach my clients how to ask the appropriate questions to the healthcare professionals who are personal trainers or Pilates instructors or yoga instructors, so that they are making sure that their needs are being met within the class, if it is at all possible. Because, as you know, in a class setting, it's very difficult to single out people in a significant group and deal with individual areas of soreness and or restriction in motion. So these questions that I'm going to give you over these Q&A sessions are going to be questions that you would ask your instructors in a one-on-one setting, so that you can get ideas from them as to what good choices or what good choices you have available to you. So the way that I started, and it's funny, when I used to teach the resistance training specialist program way back when, we would show a video, and we would show a video of a shoulder surgery, and I've always kept that video. And so I use this video, I show my clients this video because I want them to get an idea of what it looks like in a joint while in a live person, and see the joint actually articulate, see it moved by a surgeon. So I have a very unique video clip of a surgeon who is doing an assessment on the inside of a shoulder joint, and he is describing to the patient what types of problems are within this shoulder joint that he is witnessing and assessing with an arthroscopic surgery. So the thing is that from the time that we engage this video, and we see what things really look like and how they move inside, and we get a look at what osteoarthritis is and what causes osteoarthritis, what it does is it starts to make you recognize that force affects design. And so structure determines function, and force affects design. So everything that we do when we apply force to our bodies elicits some type of deformation to substance. Okay? And so the key thing is it something we can adapt to, or is it something we cannot adapt to? Well, that depends on a lot of factors that are related to force and design. So the first thing that I want to do is show you a short video. Just to remember, I'm just trying to set perspective here. If you want me to answer questions about different types of exercises, I need to be specific for you. We're going to need to do drawings. I'm going to go on video. I'm going to show you models, and we're going to take you through exactly where the forces are within all the exercises that you're engaging in, so that there's no mistake as to what the risks and the benefits are for you. I'm not going to make that call, but I'm going to enlighten you so you can make the best call for you.
Jerry, good morning. This is Dr. Yates, Carlin Yates. We're looking in this left shoulder. We're looking from the back to the front, from posterior to anterior. This needle's coming in the front of your shoulder just above the biceps tendon. This is the biceps right here. It attaches to the top of the glenoid via this big labrum or cartilage, which is quite irregular and ragged here. You've got a lot of redundancy in this cartilage that's sort of being frayed here. Now, this is your humeral head to the left. The glenoid or the socket is down here below. One thing I want to show you here is you've got quite a bit of arthritis in this shoulder. A normal shoulder should be nice and smooth and pristine, sort of like this small area right here. And you can see down here the glenoid is very rough, very cobblestoney down in here. You can see the yellowish degeneration on the glenoid, how rough it is, and then look on the humeral head. See here as I rotate the humeral head, you've got a huge, huge area of arthritis there. As I spin your arm around, see it's down to bone right there. And Jerry, this is a bad, bad problem because you're rubbed down to bone on your humeral head. This doesn't even have anything to do with your rotator cuff. It's just due to abuse of this shoulder over many, many years from your weightlifting and your training. So regrettably, we can't do a thing about that. That's just raw bone rubbing on the glenoid. You can see as I rub it back and forth, we can't resurface that at all. Now, you do have a lot of debris in this shoulder that we're going to clean up. I'm going to polish this cartilage tear up in here. I'm going to trim the cartilage down here inferiorly as well. We'll put a shaver in and tidy this up. But you can see that this shoulder has just realized too many miles, too much stress over the years, because this is the worst part of it right here. No matter what we do to your rotator cuff, you're going to have achy, deep, achy pain in the shoulder every day of your life because of this bone rubbing on joint surface. Now, the rotator cuff is a whole different problem, unrelated to your arthritis. This is the rotator cuff here. You can see the blood supply stops right here. Normally, the rotator cuff attaches to the humerus right here. See how the articular cartilage stops? The rotator cuff should attach all the way back. And look what happens. The rotator cuff stops right here. Then you have a big space of empty bone, sort of looks like the surface of the moon here. That's where your rotator cuff should be attached, is right across here where my needle is. But the undersurface of the rotator cuff is torn and retracted, sort of like a rubber band, right back up in here. See, here's the edge of the rotator cuff right here. See how thick it is? This is what we call the rotator cuff cable, because there's a crescentic cable of rotator cuff that goes all the way from here all the way back to the back. And you can see you just have a big defect here, but it's still undersurface. It's not through and through. But see this big leathery cardboard-like wad of rotator cuff? This here should be attached to the bone right here. Okay, now look in the background, you've got a nice surface of rotator cuff on top of that, and that's why your arthrogram dye did not leak out all the way through, and why our fluid's not leaking all the way through. So it's still an incomplete tear, but it's not, I mean, this shoulder's just not looking good, Jerry. I mean, we can only do so much to improve a beat-up shoulder, and I'm not sure we're going to be able to give you the relief you want to get back to training and weightlifting. This is a shoulder that should not be weightlifting. I'll be very serious with you about that. You can do some leg work and some arm work, but this is not a shoulder that can do bench presses and militaries and lat pull downs and things like that, because we'll never be able to get it back absolutely perfect the way you want it. So this is the reason why we videotape these things, so we can show you what your limitations are going to be. I'm going to go ahead and put a shaver in here and start tidying things up.
So to be clear, now that you've seen the video, we're going to take a look at just a few statements I want to finish with for this section on our introduction, and that is the slide here that says exercise, which is resisted movement. So whatever exercise you're doing, okay, whether it's raising your chest off the ground, whether it's pushing a weight, whether it's swimming, whether it's walking, everything that we do with the goal of elevating our heart rate or involving muscular contractions to improve our physiology is resisted movement, and that is exercise. The point that I want to make that is a humongous factor for every single, especially child, that goes as a lamb into a gym, okay, is that the exercise that is given to them, the resisted movements that are chosen for them, they need to be measured and or analyzed for their applicability before they are experienced. Okay? So the thing is that you don't want to make a mistake when you apply force to a joint. The thing about applying a force to a joint or putting load in your hand is that force is immediate. Okay? Tom Purvis used to say in RTS is that that load is invasive. Load is invasive. Well, it can be the most invasive thing because too much load will crush you. Okay? Too much load in your hand going at a speed can tear your muscle, can tear your tendon, your ligament, your joint cartilage. Okay? It can wear it down. Again, it's immediate. So the choice, the appropriate choice for the level of resistance in movement that needs to be performed must therefore be assessed first. So we typically want to start with the least amount of unaccustomed stimulus first, and we want to see how well that movement or motor pattern, resisted movement, resisted motor pattern, how well it is performed. Are elements of its movement completely under control throughout the range of motion that it is being performed? Okay? So that's something that I want you to keep into your head, is where does it occur when you go into the gym and you take an exercise program that someone, based on testing you for your tolerance to an unaccustomed stimulus, was trying to figure out what your best starting point was Do you see? There's a best starting point. Why is there a best starting point? Because we're trying to promote growth. We're not trying to have depletion. Okay? So the key thing is that it's supposed to be an experience of eustress versus de-stress. Okay? And that's the way that this human organism works as a cellular commodity. It's 50 to 100 trillion cells, and we want all of those cells to benefit from the choices that we make in physiology, and we don't want them to just be random or arbitrary. We want them to be assessed so that we can have the most applicable, appropriate choice made on behalf of our kids or any client or any elderly person. The idea is assess first. So what I realized that was the most valuable tool coming from applied kinesiology to me as a resistance training specialist and personal trainer and all that other stuff is that I learned priority. In applied kinesiology, we're trying to establish what's priority for treatment so that we know what type of treatment therapeutics would be beneficial, whether they be athletic therapy, physiotherapy, chiropractic, osteopathy, acupuncture, whatever method would be most appropriate. We need to test to find out what that appropriate method is, and so we need to find out what is priority of treatment. So when we're dealing with clients in the gym, or we're trying to develop an exercise program that creates eustress, positive growth of the human organism, well then we need to find out what is priority, where do we start, what's the most important thing. So that's why assessment's so important. And so many of you know, being on my table, that we are always trying to find priority. The problem is when you guys want to go back to exercise, you're always like, okay, what kind of exercise should I do? And I tell you, well, you have to get strong within your areas of positional weakness first. So it's typically isometric, and then you have to grow it out from there. But you have to be able to assess to find where the weak links are and prioritize the weak links before you build to success. So then we'll go on to the next slide. The next slide is, if not, we will be lambs to the slaughter. And that's just the truth, okay? I see people going in gyms all the time. I was in the gym. I went back to the gym last year, and I was in the gym for months, and I was watching trainers, and they had no idea that I was a course instructor, someone who's a student of science for as long as I have been. And so I'm just watching them and seeing what their choices are, and I'm seeing none of the choices have changed in all the years that I've been in the gym. People start with the same type of exercises, choices, the same exercise machines are picked, the same rep ranges are picked, the same rest ranges are picked. I haven't seen very much of a change at all in my entire professional career in the gym environment with regards to where to start properly. So, what do I see? Lambs to the slaughter. Especially the kids. Drives me crazy watching the kids get poured into dry land with no functional biomechanical assessment, no manual muscle testing assessment, and the exercises are picked for them because they're sports specific, which means nothing, and they begin a process, and then over time they seem to have gains because everything gets better in the beginning unless it's just far too much. But there's typically a positive adaptation in the early stages of exercise, but then they start to plateau and they start to peter, and we start to see that these kids get into injuries. So all of this can be prevented with proper assessment. So what should exercise be? Well, exercise should be a process of progressive experiences of challenges to our neuromusculoskeletal and epigenetical physiology. Okay, that's a lot of big words. Really, what it breaks down to is that exercise is a process. It's not a program. Okay, you don't go to the gym and someone picks some arbitrary exercise, beginner type exercises for you, and without any assessment just writes them all down, draws little stick people for you, and puts them down on a sheet, and then gives you your rep range based on what you said your goal of toning or shaping or whatever the generic idea was about how you want your muscles to look at the end of the day. And so it's never a program. It's a process of progressive experiences. Why? Because we're trying to create eustress. So we want to make sure that the choices we make are the least amount of unaccustomed stimulus, that you gain mastery over the requirement, that you are able to heal within the proper spectrum related to your goal and related to your health, and that you are able to move progressively under observation, under good choices for adaptation, from one stage to the next stage to the next stage of experiences, constantly improving your ability to adapt to resisted movement. So what are we challenging when we're in this process? Well, we're challenging our neuromusculoskeletal system. Well, that's the reason why I say that is because neuromusculoskeletal means that every muscle that operates a joint is innervated by a nerve, and predominantly what regulates its tension is nerve fibers. These are spindles that surround muscle fibers and they regulate their rate of change, their distance of change, and the level of tone that they have in during their stabilizing roles as well. So the thing is that the muscular system is not without a skeletal system, and it's not without a neurological system. It is a neuromusculoskeletal system. And when I come down and I say epigenetical, I chose epigenetical because I want you to understand that we have to think about the expression of our genes being a result of the interaction that we have with our environment through our five senses. So our five senses regulate input into our cellular body. So those five senses make up the exercise experience, and that ultimately has the most significant effect on our physiology. So when we choose to use the right mechanics, understanding the architecture of bony design, understanding the architecture of muscle, understanding the physics and trigonometry and the rules of engineering around how these mechanisms were supposed to move, then we can look at the adaptive roles that the neuromuscular function will have on this design, and we can look at physiology and how we want to manipulate the stimulus of the senses to create the least amount of unaccustomed stimulus that is progressive, that is seamless in progression, so that people are always having success no matter when they start it in life. They're always developing in process and in progression. So I'm going to end with that as my introduction.